Hello, class. We are going to be talking about nutrient delivery for a little bit. This is the class that was canceled that I wasn't able to make it in for. So I'm doing this recording so you can see the PowerPoint. Let's go through the notes together so you can take your own notes, kind of understand this a little bit. And then I'll review some things on Tuesday. But it's definitely beneficial for you to hear this and go through this. Hopefully on class, Professor Lavelle was able to show you some tubes like NG tubes, PEG tubes, and the IV catheters that when we get to that point in the presentation today, it won't be too unfamiliar, and at least you've seen that. So we are now starting the clinical nutrition section of our textbook, and from this point, we're going to do this today, and then next Tuesday will be weight management, and then we'll really get to those disease-focused problems and then relate nutrition to them. So new section of the textbook, we're really getting through this. And as we go through today's plan, our focus for the most part ends up being more the hospital patient, because now really think we're in clinical nutrition. So, you could think home health care environments as well. I know some of you have some experiences working in extended care facilities, some hospitals, so maybe you can even think about your own experience. And I know some of you have shared with me family members with nutritional care needs, so each of you have your own perspective. Some of you may not know a lot of what I'm going to talk to you about today, but it'll be exciting stuff. If you plan on continuing in nursing, you will learn much, much more about. But we always like to get a good foundation in this class. So the objectives we're going to get through today, and I'll try and make this pretty speedy. And if you need to rehear anything, just pause and rewind me, because I'm just going to be kind of going through my notes and hitting the high points that I want to make sure you get. We're going to talk about nutritional care services today. Identify the methods, when we talk about a regular meal tray or extra oral supplements or the tubes. And lastly, the end part of their class is where we actually talk about the use of feeding tubes and parenteral therapy. And so, our ultimate goal through all this, is that healthcare providers will assist the client to combat malnutrition. So I kind of put that right up there as our goal, and be thinking about that through everything we talk about. That it all goes back onto preventing that malnutrition. If we spent a good part of this semester already talking about healthy choices, macronutrients we need, vitamins, minerals, water, and people maybe even at risk for malnutrition. So we're going to talk about that risk element some more and what we can do, and in general the hospital setting to combat that. So the book, first of all, starts with nutritional care services, and I'm going to go through the outline of the textbook, so if you do have any questions, or you need more detail to really understand what I talk about today, remember the stuff is in your textbook as well, and you can ask me, send me an email, or ask me next Tuesday if I can clarify anything for you as well. But good nutritional care for that patient really is going to save a lot of healthcare dollars, as well as get that patient in the best care that they can be in. And if you hear my son, he's coughing in the background, so just excuse that. He's nearby. But, to offer the service to the patient involves a lot of people. So we're going to talk a little bit about the healthcare team right off the bat when we talk about assessment. And I say involves members of the healthcare team. And nutritional care services may vary within different hospitals, different settings, whether it's a rural hospital, a larger hospital, more members of the healthcare team may be involved. But when I say that we can really include now a registered dietitian, I've given you some examples of things that the registered dietitian help us out with, and we'll talk about that a little bit today. And the assessment component, this is really geared to students that are going to go on to nursing. Nurses are the first line of people that see the patient, that ask really good assessment questions, that do the physical assessment, and really even identify some nutritional risk. Taking that information to the physician, getting other members of healthcare team involved. Like, for example, if the patient was having any trouble swallowing, get a speech therapist involved. If their lab work indicated a lot of malnourished and they looked awful, get that registered dietitian involved. Make sure that the doctor's aware of things that you see. If you do an assessment of what they normally eat at home and you see a lot of gaps in their nutrition, you can bring some information up. And there was actually, if you have your textbooks around, page 308 had some great thoughts about with your assessment, who's at nutritional risk. And I'm just gonna kind of refer you to that page for now if you have that open. But it's people that maybe have, I've talked about how we can measure protein in the blood, maybe have low albumin levels, maybe have poor swallowing ability. They say that they've had a recent weight loss or haven't been able to eat lately. Trouble with that. If they're here, we talk, in a little bit, I'm going to talk about chronic versus acute illness in the hospital as well. But a lot of assessment factors include, and nurses are right at the front line to catch that kind of stuff. And monitoring, reassessment is needed. We always get baseline information like weight, lab values, get that food diet history, figure out what's going on with them. And then it really depends on the patient, how sick, what's going on with them. Are they a surgical patient, going to be here a long time? Are they here for a quick run of antibiotics for a couple of days? So if the patient tends to be here in the hospital for longer amounts of time, they're going to end up needing more monitoring. The sicker they are, they need more monitoring. And I put client care conference on there, and that really just means, that's when members of the team gather information and bring it and talk about it. And we even do this kind of stuff at the hospital. We do things like bedside rounding or collaboration right there at the bedside with the doctor, social worker, registered dietitian, anybody that could be involved in their care. We look at maybe their weight trends, changes in their medical condition, deterioration maybe, as their diet order changed. The resources maybe that they'll have available at home that they need. Social worker could help with that. So with all the information, we can really determine the best care of our patient. And that ending part, counseling, kind of means like education. Always making sure, even as if we're doing bedside rounding and we're including the patient in the care, that the patient is always in the center of our care. And different facilities have different procedures and policies. Let's talk about diet orders a little bit. This stuff's kind of given, some of it. Diet manuals pretty much include information about the food service operations within the facility, what a diet is defined as. You're going to see slight variations between different hospitals. The diet order, you can think of it like, a medication order. It is something ordered by the physician. And, the nurse is implementing the orders. And we can't really just order diets for a patient because it needs evaluated by the doctor. And they are ordered. And special diets, we'll talk about some examples of this, but maybe a little variation of nutrients, maybe higher or lower calories, texture, consistency. We can actually modify diets quite a bit. Maybe if we need to make their liquids a little thicker so they can swallow easier. Because if you don't know it, more people that have risk with swallowing actually do poorly with thin liquids. So we might need to thicken up their beverages. We might need to make sure that they have easy to eat type foods. And just for an example, maybe they need to be on a low sodium. It's a diabetic that needs a low carbohydrate diet, low potassium. We can modify it. Okay, I threw in a couple questions. When caring for an elderly client who has difficulty chewing, the nurse identifies which of the following diets to be most appropriate to use. Okay, so keyword on here, and just get your brains thinking. If you don't even know, we'll learn from this question. The keyword on here is the fact that this elderly client is having difficulty chewing. And what type of diet would help with that? And if you think about the word on here, mechanical, and how I talked about with the whole digestion, mechanical digestion starts with the mouth with chewing, and if we're having trouble chewing, they can actually order a mechanical soft diet. And what that'll look like is okay, this is going to sound awful, but maybe it looks like Think about meatloaf, how easy that would be to kind of, not a lot of chewing compared to that with a chicken breast. Meatloaf would be much easier to eat. Mashed potatoes, just easy to eat things. If a patient, sometimes I'll even have where they don't have their dentures here in the hospital, and so they can't chew safely, then you might order a mechanical soft diet. A full liquid diet, high protein diet, and parade diet isn't necessary in this case. If the client was on this type of diet for more than 24 hours, meeting nutrient needs would be a concern. Can you cover your mouth, please? A clear liquid diet, B, a full liquid diet, and C, a regular diet. Or D, a pureed diet. And so this kind of, if you read about it in the textbook, where this would be more risky for malnutrition if they're on this diet for an extended amount of time. So think of it as this diet has the least amount of nutrients, and that's going to be a clear liquid diet. It's really, really limited in the amount of nutrients. And I have a picture of some diets coming up here real soon. So common diet orders, regular, that's about as normal as you can get. And sometimes the nurse is responsible for advancing diets as tolerated. A great example might be after surgery. Let's say they had surgery on their bowels, their intestinal surgery. And there for a while, the doctor's going to want to have them take it really easy for how much food they're introducing back into the system. So oftentimes they'll start with clear, work up to full liquid, work up to soft, and then regular. So that's an example of advancing something up. So, and like I mentioned on that previous question, clear liquid diet has the least amount of nutrients in it. So it really harms the patient, keeping them, for one thing, not eating or drinking at all, or even on a clear liquid diet for an extended amount of time, because it can be really risky and they can deteriorate really fast in the hospital. Think about how we talked about older adults over 65, how, their lean muscle build goes down and they don't have as many protein stores, and they tend to get malnourished a lot quicker in the hospital. So it's good things to be careful with. Just some alerts to keep you thinking about. You'll have many, many experiences if you continue on in the nursing program, and the first thing you start doing in the nursing program is assessment and what things to ask, like the older adult is the focus. I'm going to pause this for just a moment. Okay, let's move on to the next slide where I have some pictures. And for this in class, I was actually going to have you guys try to identify which diet is which. And I was going to ask you, which one do you think is a full liquid? I have an example of a soft diet, a pureed diet, and a clear liquid diet. So as you're looking at those, if you're making good guesses, let's start with right at the top left is an example of a clear liquid diet. And clear liquid, by definition, is any transparent liquid that can be poured at room temperature and that you can see through. So you can imagine how that would have the least amount of nutrients in it. But it's appropriate for many, many, many times in the hospital to do. Especially, we talked about the digestive system, and if we're trying to take it easy on their digestive system for a little bit, the clear liquid diet has the least amount of, mechanical digestion, chemical digestion, really easy to digest. Now on the top right, that's an example of a pureed diet, and if you can tell by looking at that, yes, those peas are actually made out of a mold. They have some really incredible looking molds. I've seen peaches being made out of, it's actually a pureed liquid, and they can make the consistency pretty soft to make it, visually appealing. And that might be some kind of meat formed into a shape, and some mashed potatoes. So pureed diet is something that would literally need no chewing and would be really, really safe and easy to swallow for someone. Bottom left is more like a regular diet, more like regular. Could be a little bit soft if that meat was soft enough, and then the little potatoes and green beans wouldn't take too much. mechanical digestion. And then on the bottom right is actually examples of a full liquid diet. And they can have anything a clear liquid diet can have, but now you can have milks, that's cream of wheat. Again, it's any liquid that can be poured at room temperature, but you can not necessarily see through them. Just some pictures to get you thinking. All right, some importance of nutritional care and why, I always like to try and get your attention of why this is really important, because malnutrition is associated with acute and chronic disease and is really common in the hospital setting. It's actually said that about 50 to 60% of the patients even in the hospital are dealing with malnutrition. And you got to think some of them are coming into the hospital already with not adequate nutritional stores. Maybe they're dealing with a chronic illness like COPD, and now they're in with an acute infection. So you have acute illness that brought them to the hospital, and then they have their compound complex chronic illnesses on top of that. Nutrition can actually be a major influence on the length of hospital stay, because we know in the hospital the better nutrition the patient has, the faster and better that they're going to recover, because a malnourished patient does not have the ability to recover as well, gain muscle to get up and ambulate after a surgery, maybe not have good protein stores to fight the infection and really recover. So the longer they're in the hospital, it really gets concerning that you want to really focus on that nutrition. So you can see already how nutrition is a big impact in the hospital. I mean, any patient that's in the ICU, will usually have a registered dietitian on the case. Where I work at the hospital, every unit has a registered dietitian assigned that kind of floats around and checks on the patient. Looks at their height, weight, their age, their lab work, and calculates calories, and then assesses their input and see what they're having. And I mentioned the morbidity and mortality rate, and if you don't know, morbidity is actually the rate of being diseased. So morbidity actually means the rate of having a disease. Now, malnutrition is associated with more morbidity, and then mortality is a death rate. So increased morbidity and mortality with poor nutrition stores. And then one interesting thing I mentioned the other day when we were talking about the older adult is hospital-induced malnutrition, which has the word iatrogenic malnutrition. This really means nutrition related, malnourishment related to being in the hospital for an extended amount of time. They're going maybe without food or food, drink, and that may be because of the physical condition they are, but it ends up happening while they're in the hospital. Drug therapy might impact this. A variety of diagnostic tests going on. Maybe they're having a lot of pain and vomiting related to what they're here in the hospital for. It's really an issue in the hospital. It's extending hospital stays. It's costing hospitals a lot of money. And really that, ultimately it's all about the patient and their well-being. So some methods, just an example to combat this issue. That's a here and now issue going on in the hospital. Getting a good baseline height and weight is important. And I always teach my students that, the baseline is important because we're watching for trends. We're going to watch for trends in weight loss. If they're applicable to get weighed every day, we're going to be watching those trends. Communicating and being a team player with a registered dietitian, the physician, and also including that patient as part of the team member, because they know themselves more than anyone. And monitor their intake. And this goes a lot with nurses and maybe the patient care assistant on the floor, getting good, accurate food intake numbers. That just goes back to recording. Some people actually end up being on a calorie count as well, that the nutritional staff will assist with that. How they're tolerating it. Have good knowledge about what it means to have good nutrition, and that's why you guys are taking this class. Monitor MPO clients. MPO status means that they are not eating or drinking. And this may be needed at certain times in the hospital, but you got to watch the length of time. Why are they still not eating or drinking, and really just advocating for that patient. I've been watching this week I met with a young man on Monday. He was a newly diagnosed diabetic. He was 25 years old, and he was in with actually pancreatitis that was associated to his diabetes, and he was on a clear liquid diet because we talked about those pancreatic enzymes that are secreted, when we eat something. And someone with pancreatitis, if you feed them when their pancreas is already flared up, they actually are in extreme amount of pain and don't recover really fast. So they actually had him, I think, on a clear liquid for a day. Then his lab work looked awful and he had more pain, so they switched him back to not eating or drinking. And when I saw him yesterday, they were just starting clear liquids up again. And I actually looked at his levels of protein in his blood, and just in a matter of a few days, he was malnourished. His protein stores had dropped. So this is really happening. Recognizing signs and symptoms of malnutrition. And I'm going to have to defer. You're going to learn all the norms of physical assessment for a good nourishment as you continue on. So recognizing signs and symptoms of malnutrition. The one of the most obvious ones can be weight loss, just really, really easy like that. And lab work. Monitor fluid intake and output, of course, and keeping hydration is really important. So if you have a patient that's not eating or drinking, a lot of times you want to make sure that they're at least getting IV fluid. Okay, so just some nice hints. We are actually going to talk about, methods of nutrient delivery now. How are we going to get nutrients to the person? We have the oral delivery, and that's by mouth. That's those meal trays that we just talked about. Enteral tube feeding. We're going to talk about specifically NG tubes and PEG tubes related to that. And we have parenteral nutrition, and that is venous type therapy we'll talk about. So a few more things about oral delivery. We got the menu. They have the certain diet that they're ordered. Encouraging them to pick their own foods will research has shown they eat better that way, and it just makes sense. I mean, if you can pick out your own food, you're not only promoting independence and letting them have control over some choices that they have in the hospital, but the fact that they will eat good is really important. You want to keep that psychological and physical pleasure associated with eating as much as you can. Having a good eating environment, watching odors, sights, sounds in the hospital, position for safety. I'm not going to go into, your book expanded on a pretty good section of one of the pages about assisting the disabled client and assisted feeding versus self-feeding. I'm not going to go into detail of that. And, it really goes all about just providing them with safe care and assistance to combat malnutrition. But there's a lot of people that need assistance, maybe with the swallowing, maybe they're visually impaired. Maybe they cannot feed themselves due to strength. Maybe they had a stroke. Occupational therapists also could be an example of another team player. Just visited a patient yesterday, and they had an occupational therapist on the case because had a stroke and couldn't use their hand really well to eat. So making sure they have, and stroke patients right after a stroke are very tired too, and they need a lot of rehab, and they can get malnourished because of the lack of energy and strength to even feed themselves. Now, supplemental feedings is going to be the first thing we're going to talk about today. Many clients are unable to consume a sufficient amount of calories because of maybe a little bit of examples of anorexia aging that we talked about, either chronic or acute illness, and they have an increased need for nutrients when they're combating an illness. So one of the first steps we can do, maybe rather than 3 full meal trays, is offer more smaller opportunities for meals between those times. Monitoring the intake, evaluating, we can do liquid supplements. We are actually going to spend some time talking about now some examples of supplemental feedings. And I encourage you to really know these well because you'll need to really understand the difference. And I'll try and keep it really simple. And think of supplemental feedings of it's something in addition to their intake that they're already having. Let me give you some examples. Modular supplements, the first one on here. It contains a limited number of nutrients, but it's added to their meal, to their regular diet, so that they help increase their nutrition. Now, the best example I can give you, my image up here is Beneprotein, and it's actually a powder that has a good amount of protein in it, a good amount of amino acids, and literally mix it into mashed potatoes, applesauce, pudding, whatever, and it's just extra nutrients. It's supplemental nutrients into their meals. I see this a lot used with people that have wounds that they really need to heal well, so they need some extra protein. Now, intact or polymeric formulas. Um, Now remember, all this, we're still with the GI system. So this is used with a GI system that's functional and needs all the essential nutrients in a specific volume. Now you may have seen these before, heard of them. Ensure, Boost, Jevity. It's used when the formula, I've seen this used when the formula is the sole source of their nutrition, or even getting like Ensure little shakes or Boost shakes in between their meals or on a meal tray. And it's just because we know they're at risk for nutritional limitations, so we're giving them more. The intact part of it and how you remember is that when you compare to that next one, elemental or pre-digested, those formulas are extremely easy to digest because they have them in a very elemental things. Now, remember how we talked about carbohydrates, glucose, fats. You got your glycerol and the fatty acid chains and the proteins, amino acids. Those things are the most basic forms that are very easy to digest. So the intact, all the nutrients are actually intact, whether in comparison to the other one, the elemental or pre-digested. They are extremely easy to digest. So there's small peptides, there's the chains of the fatty acids aren't as long. They end up being really, really expensive. So I don't see them used too much in the hospital unless they're determined they're still trying to use their gastrointestinal system, but their gastrointestinal system just cannot digest it well enough. So they'll use this pre-digested formula. Then the last one is just disease-specific formulas. Maybe if they have kidney problems, liver problems, and the formula is actually tailored to meet the needs of that individual person. So these are 4 examples of supplemental feedings. Now we're going to switch over to enteral tube feedings. A good rule of thumb is you always want to use that GI tract when possible. So enteral tube feeding means that the feeding of the formula, the liquid, is going to actually get to the stomach by way of a tube and continue on into their client's GI tract. With some medical conditions, oral feedings is just impossible, insufficient, or even impractical. I put some examples on here of where it would come up where we need to use an enteral tube feeding. And enteral is actually from the Greek word enteros, which means intestine actually. And you'll learn much more about these, and you'll actually learn how to put in an NG tube when you're in nursing school, and you will get to do that one day if you continue on. So some examples, mechanical issues with chewing and swallowing. It is just not safe for this patient to swallow. I think the best example I can give you of that is someone that just had a stroke. Their brain has been lacking oxygen, and their ability to physically swallow is no longer possible. Then they would have to do something like an enteral tube feeding for their safety. Maybe they have an intestinal disease and can't absorb food well. Maybe they refuse to eat or cannot eat. They don't have the strength to eat. Maybe they're unconscious, in the major car accident where these people are in trauma and they're on life support. They're not going to be chewing or swallowing anytime soon, but we can still get those calories into them by way of an enteral tube feeding method. In many of the commercial products that I talked about on the previous slide under supplemental, especially those intact polymeric formulas, we actually will use those formulas with this. So oral supplements should always be considered before tube feedings. And tube feeding should always be considered before venous nutrition that we'll talk about in a little bit. Tube feeding is overall safe, it's less expensive than IV feeding. And the nice thing about enteral tube feeding is we're still using the GI tract, so we're still encouraging normal digestion process. It's good to give somebody those intact nutrients that aren't pre-digested, so the body still has to produce the secretions and enzymes necessary for digestion. So the tubes we're going to talk about specifically are NG tubes and PEG tubes. Some of you may have heard about these, some of you might have no idea what I'm talking about, and that's why I actually brought in the props to use and show you. But I did ask Professor Lavelle to show you those and review them a little bit with you, so hopefully you have that in mind as I talk about things a little bit further. So the difference between an NG tube and a PEG tube. I have some pictures for you, and let's just talk about this a little bit, because you really can't grasp the whole enteral tube nutrition until you see these and kind of have some examples of what they mean. But an NG tube is the one on the left, and that is the one that I said that you will know how to put in someone one day, and nurses are allowed to do that. Nurses can do the one on the left. A doctor will place that PEG tube. The nurses will not do a PEG tube insertion. So an NG tube, if I was standing in class, I'd be holding it in front of you. Well, hopefully you had a chance to see those. But an NG tube just looks like a long plastic cord, and literally the nurse will do, eye a measurement. Gonna get a measurement down. It's not a comfortable procedure by any means for the patient. They need a lot of emotional support as they get this done if they're fully awake, because it's not a pleasant feeling. You're literally going down the nose into the stomach. You can see where the tip of that NG tube would sit, right into the stomach. But what this gives them is they don't have to swallow, they don't have to chew, and you're giving them some liquid nutrition right to the stomach. The stomach still has to produce acids, the intestine still has to do what it always had to do. We're just bypassing the oral route, is simply all we're doing. It's like a bypass tube. NG tubes are also used on the short term rather than the long term. And the PEG tube is on the right. That stands for percutaneous endoscopic gastrostomy, which is inserted right through their skin. That's what the ostomy part of gastrostomy means. It means we make an artificial opening through their skin and literally right into their stomach. You can see how the tube placement, where the nutrition ends up going, is in the same spot. NG PEG tube. The food goes right to the stomach. And this is used more for long term. If this patient is deemed to not be able to use that oral swallowing, chewing method for a while, they'll use the PEG tube. Because those NG tubes get awfully rough on a patient if they have them for 10 days or more. They irritates the back of their throat, irritates their nasal cavity. It's something foreign that doesn't feel good in there. It can irritate their esophagus tract, so it is not for long term, that NG tube. A PEG tube would be a long-term method. Just a few more things about enteral tube feedings. You can use continuous or intermittent feeding. And what this means is, in the hospital, for example, I would have a doctor's order. It may say something like, let me go back and see my thing. It may say like Gevity at 40 mLs an hour for that patient. And a lot of times when we start them out on enteral tube feeding, let's say I put in an NG tube and I'm starting their nutrition, the nutritional needs are calculated by the registered dietitian. They are really great at doing that. They're good at recommending what type of feeding, because we can use feedings for diabetics that might be lower in carbohydrates than others. And a lot of times we start low because it does take a little bit of adjustment for the patient to tolerate that. It does take a little bit for the stomach to get used to having that and digesting normally. And then we just increase the rate until we get to goal. Intermittent feeding would, rather than continuous, it would be in certain times of the day that we would do the feeding rather than continually. There's people at home that, they're up and walking and they have a PEG tube because, let's say, they had throat cancer and they had radiation therapy and treatment for that, but they can never safely swallow again. And they actually will administer their own tube feedings certain times of the day through the peg tube. So this isn't just always right in the hospital. If you're a home care nurse, you're going to be dealing with this in extended care facilities, working with children that have these types of tubes. You know, you may see this at lots of different aspects of nursing. Nursing is huge. And so monitoring the tube fed client, you know, nutritional status, making sure that they're tolerating the tube feeding, and any signs of malnourishment you were seeing or were at risk of seeing will hopefully be improved, or at least you won't see the deterioration. And you're just really think about macronutrients, what they are. You're providing that patient with energy to survive and to combat what's going on with them in the hospital right now. Monitor their fluid balance, because within the tube feeding we count as fluids, and we can actually, you'll learn lots about looking at lab work to even assess the fluid balance and hydration. And GI tolerance, really how they're tolerating. And just as an FYI, like when you assess NG tube and PEG tube in the hospital, we assess it periodically, make sure the tube's in the correct placement. And we actually can take a large syringe. I hope Professor Lavelle showed you. I had some down there. We can actually pull back on the syringe and assess that tube feeding is actually getting digested, because at first sometimes it may be high. We actually call it residual tube feeding that's in the stomach. We check it. It's one thing we assess for. We also, I was going to say something else and I just lost it. That's okay. And, you know, with the NG tube, the biggest concern of that, you might have read about this, is if you read through this, and I'm not holding you accountable, by the way, to anything that relates to nursing care. There was a lot of detail in the book, but you can see I'm not focusing on it with our slides, because I don't think you really need to know that right now. Because if you continue on in nursing, you'll really get the skill component and the monitoring component for now. But for right now in this class, I just want you to be exposed to other types of nutrition. You know, it's not just eating. You know, we can't rely on that all the time. When people get sick, we have to look outside the normal and use these other things. Tube feedings are very, very commonly used in the hospital, especially for those people that are very sick. Okay, so on the other spectrum, we'll just quickly talk about veins. We got to talk about veins because there is a different type of nutrition that we can use called parenterotherapy, where we're literally putting the nutrition in the veins. Now, this would in no way be the same solution of tube feeding that I just talked about with enrolled tube feeding. This is pharmacy prepares this. It's very specifically given to what a vein can tolerate. But you can actually give fats, amino acids, glucose right through the vein too. Now, in these situations, we're doing that because their normal gastrointestinal system cannot tolerate it for one reason or another. Many, many reasons. And so we're doing this. You can see I have some pictures and I had some examples today and I had to show you a little bit about this for you to really understand the peripheral nutrition versus central nutrition. And the PPN, the peripheral parenteral nutrition, is a shorter catheter. Oh no, I'm so sorry. A longer catheter. I have a picture of it right there. The PICC line. Percutaneously inserted central line is what a PICC line is. And physicians insert this, and actually nurses can get trained on inserting this. We just started doing it in my hospital. There's a PICC line team of nurses. So many things you can do in nursing, and they actually will place PICC lines on patients that need not just nutrition, but maybe long-term antibiotics. And so it's a longer line, and it's a little inserted farther away from the heart. Okay, let's look at that picture on the right. It's a centrally inserted line, and you can see kind of from the insertion point, I don't know if I can use my mouse. Yeah, it's kind of like inserted right around here, and it actually gets right up to the vein that goes right into the top part of your heart. So subclavicular vein right now down to the heart. So a lot of things to learn in anatomy and physiology. You know, your vein placement and how your heart works and everything. And I don't expect you to know all that right now. But this is actually a picture of what the PICC line would look like outside the skin. Often used, you know, in the arm and this brachial vein right there. This is what this would look like on the outside. It's a centrally inserted one. The centrally inserted ones are seen a lot in the hospital, and PICC lines are getting definitely more and more commonly used. Okay, so let's talk about a little bit of indications for parenteral therapy. I'm going to go through all this, and then I'm going to go through the tip sheet that I made you guys, that you can hopefully understand this a little bit easier, because this can be a lot to really grasp on, you know, talking about gastric tubes and talking about venous nutrition. And I'll be happy to answer any questions next Tuesday. I'll start the class next Tuesday by asking any questions and probably clarifying some things too. But we can use peripheral, like a PICC line, if it's for a shorter amount of time, less than 10 days, and if they can't tolerate the central line or the enteral nutrition, they'll use a PICC line. And the central line, the one closer to the heart, that's a physician place, can be used longer for nutritional support. And remember, this is outside the gastrointestinal system. And I find it really interesting. If you think back on the digestive class we talked about the small intestine and those microvilli. I talked with you about how they help with absorption and how they shrink so much with malnutrition. And I talked about that cycle a little bit that they get in, where malnutrition causes malabsorption, can cause diarrhea, and then, you know, the cycle just continues. What can actually happen when we're using venous therapy and not our GI system anymore? You know, our stomach's not producing as much enzymes, our small intestine, our intestine, large one, isn't producing as much as it normally does, so it actually can shrink in size and atrophy a little bit. So when you ever take someone back from venous therapy and now their GI system is working and we switch back to the GI, they definitely need a big transition and a lot of time to be able to tolerate that well. I will talk more specifically on Tuesday and just clarify anything more, because I know this can be really hard to explain, especially explaining here when I don't have the equipment right in front of me. So I hope you can have some time to look at the tip sheet. I put this together actually last year when it really stuck out to me. The students just had a hard time understanding the difference between enteral and parenteral nutrition. So I kind of put it in an easy to understand thing. Let me just go over it real quick. So enteral nutrition was on the top of your paper. Let's look on the left. And what it is. Enteral nutrition. Remember, we're using NG tube and PEG tube. It's intact formulas and elemental formulas. They're commercial products. They contain specific nutrient composition and a controlled consistency. That's what it is. That's what's going in them. And we use it. Some examples. Enteral nutrition is used when the client can't consume adequate nutrition and calories, but maintains a partially functioning GI system. So we are keeping it within the GI system with enteral nutrition. I really want you to have that as a take-home point. Some examples. They can't chew or swallow safety. I talked about that. A premature infant, too weak to suck from a bottle. I shared a personal experience of my son being in the hospital, and for his nutrition, had to have a feeding tube. You know, couldn't have that. Didn't have that sucking reflux yet. A neuromuscular impairment, someone that had spinal cord injury and they are paralyzed. They are not going to be swallowing or chewing for a while. They're going to get a PEG tube. Medically unconscious client. They cannot swallow. Why? Why do we do it? To prevent malnutrition and ensure that that client gets complete nutrients. And we do it, how? By bypassing that oral route, but it stays in the GI system. Common routes are NG tube and PEG tube. There is also a J tube, a jejunum tube. So if you hear J tube, something like that does exist. NG tube used for short term, Peg tube use for long term. Okay? Those are key points. Parenteral nutrition. Let's look on my screen. It's on the left. What? Parenteral nutrition includes lipids, amino acids, dextrose, electrolytes, vitamins, and trace elements in sterile water. So it can include all their nutrition. Pharmacy prepares this for us to administer, and nurses administer this stuff. When parenteral nutrition is used for a client when their GI system is not functioning, or when a client cannot consume, tolerate sufficient nutrients orally or enterally. Some examples of who have an intestinal disease. We have to bypass their GI tract, like it's not usable. Colon cancer, pancreatitis. That's a really common one, pancreatitis. Extensive trauma, where we just cannot use their GI tract right now. Why is the same reason as our takeaway point from this whole class, my key to prevent malnutrition and ensure client gets complete nutrients. And we use under how that vein for nutrient delivery. So we can use total parenteral nutrition, using a central line like a PICC line or a CVC line, using it for long term. We can use more of the shorter line, what I had in class to show you, a peripheral parenteral nutrition. It's using a short peripheral IV site. I do not see this method used very much. It's because the vein with that small of an IV gauge and where it just can't tolerate it. It really can't tolerate the amount of dextrose that it needs to put in there. But it can be used if the central line is not available, or if it's for very short term. I'm talking like a day or two, maybe. Maybe they would do it. But that really wraps up our day. Our day of you listening to me. So thank you so much for taking the time to listen to this. And again, I'm sorry I couldn't in class to talk about it even more specifically. I hope you learned a few good things, because you will see things from this on quizzes on the final exam. So I definitely hope you enjoyed watching it. Let me know if you have any questions.